Good afternoon, everyone.
Yes,
And we are just in the middle of a rather complex case. So let me go through the case with you. First of all, let me introduce Heart Foundation. So for those of our guests who have come from abroad, National Heart Foundation Hospital Research Institute is a non-government, non-profit organization. It's a 480-bedded tertiary cardiac care hospital, fully equipped with all modern facilities. And we have 5 fully functioning Cath labs. And last year we did more than 6,000 PCIs. We started doing left main PCI in 2007. And last year we did around 273 left main cases. So let's go to our patient. Now this is an 82-year-old female. And she suffered an old inferior myocardial infarction a few months back, and since then she's having angina on minimal exertion, even with maximal anti-anginal therapy. So she has post-MI angina. She's hypertensive with an ejection fraction of 46%. And in fact, her angina was so bad that they had to do an angiogram. This was done outside of Dhaka in another center because they could not control her angina, and then she was referred to our hospital for revascularization. This is a angiogram you can see. So there is highly calcified left main, distal left main, 90 to 95% stenosis. And this involves the origin of both the LAD and the LCX. The LCX is a narrow caliber vessel, heavily calcified from its origin. The LAD, as you can see, is heavily calcified, also has a 90 to 95% long segment stenosis from its proximal part. The RC is a dominant and calcified vessel having 80 to 90% stenosis in its proximal part, and starting from there, and then it has a CTO in its mid segment. Now, if the panelist wants to discuss this case, we can do that, or I can tell you what we have done so far. So,
Madam, what is your plan for this patient?
Yeah, so you want me to tell you, okay, great. I thought that you would want to discuss. So what what we have to understand a few things here. This is an 82-year-old lady, and she's very frail. Her weight is low, and she has no support. So the left main is severely diseased, as well as, and the left main is severely diseased, and also she has severe disease in the right side. So she has no support. Now what do we do here? So we have to be obviously very, very gentle, and we have to stage the procedure. So that is what we did. 1 week ago, last Thursday, we first approached the right coronary artery. And as you can see, the right coronary artery is very diffusely diseased, has a CTO, and we struggled with our run-through wire and with the pilot 50 as well. So here you can see a microcatheter and a pilot 50, and the pilot 50 is not, so first of all, this is a run-through actually, and we took this run-through to anchor it to our large RV branch. So we use this as an anchor because our wire would not pass down. So this we kept in the proximal right RV branch, and then we tried to cross the right coronary with first the run through, then a pilot, and then eventually with the help of a microcatheter and a Conquest Pro wire, we were able to cross the RCM. So as you can see, the Conquest Pro first goes into a small branch, and then we negotiate it into the branch proper, RCM. Once the Conquest Pro went into the right coronary artery, we took our microcatheter, and then we exchanged our Conquest Pro wire for our run-through floppy wire. As you can see, we struggled to change, and the micro is really having a tough time going down, and we are really needing to screw our micro to go down. So there was such a lot of calcium there that we had to really struggle taking our micro, but eventually we were successful, and we exchanged for a run-through floppy wire. After we changed to our run-through floppy wire, we then took a scoring balloon, and this was I think 2.5 by 12 scoring balloon, and we did scoring balloon inflation through the entire length of the right coronary artery. And as you can see, we have a 1.5 millimeter by 10 balloon in the RV branch, which is acting as an anchor for us. So after doing scoring balloon, at this point of time, we were able to take our IVUS catheter. And with the IVUS, we saw that there was really a lot of calcium, more than 270 degrees of calcium are in quite a bit of the place. We can go to the IVUS if you want to now. The IVUS that we did last week, and so the IVUS convinced us that the calcium is very high. So again we did some NC balloon dilatation, and then after that we took stents. So let's go to the IVUS. So if we are having problems with the IVUS, maybe we can just show them what the results were with our stenting. Can you see them? Can we show them the IVUS? Yes. So just hold on a bit. So here you see the challenges are that this is an 82-year-old female patient, and these are the patients that I was talking to you about today in our stable coronary artery disease. Now these patients really suffer. Patients with multiple comorbidities, elderly patients, frail patients, high bleeding risk patients, unique subset of patients that we are seeing more and more, multiple comorbidities with severe angina, and the angina not only affects the patient, but it also compromises the life of the family because they have to see her suffer day to day. And even with maximal anti-anginal therapy, and in many instances they cannot tolerate it, the patient still has pain. So the problem with these patients are that the surgeons usually refuse to do surgery because of multiple comorbidities or because of their age or because, like our patient, she's very, very frail. So frailty is also something that is very hard to define, and we have to treat these patients, and that is the challenge. So please can we go to the IVUS? He's got the photos of the IVUS right now. So let's shift to the IVUS, please. So you can see this is the RCA, so almost 360 degrees of calcium, and then here, so very highly calcified vessels. So we tackle this with NC balloon, high pressure NC balloons and scoring balloons. After tackling it the best, because here we did not use rota. We felt that she needed the support of this right coronary artery, and only then would we go and use the rota. So you can see the plaque burden, you can appreciate the plaque burden, but the scoring balloon has done quite a good job, and you can see some cracks there, can't you? So we then proceeded to stent this vessel, and let's go and have a look at the angiographic view of the stenting. So we deployed 2 stents, 2 drug-eluting stents, and please, we deployed 2 stents. So these are the 2 stents going. One was a 338, deployed it, and then the proximal, because as you can see, the RCA was diseased right from the ostia. So we had to treat this vessel up to the ostia. So deployed our first stent, then took our second stent, and we made sure that we covered the ostia properly. So here we gently disengage our catheter to position our second stent near the coronary cusp. We position our stent properly, deploy it, then do post dilatation. And this is the final result last week. So our patient tolerated the whole procedure well, and the IVUS run also showed that the stent was properly apposed, no malapposition, under expansion or stent fracture. And this is the final shot, yes, 7 days ago. Now, this is today. We do a check angiogram of the right side, and you can see that the right side looks fine. Now we go to the left side. Now the left side is a nightmare, I can tell you. So you can see the calcium, right? This is angiographically the calcium that you're seeing. And we took a shot also with a bit of dye. Where is that? So you can appreciate the extent of calcium. You know, it's like, see? So it's like the whole thing, it's like a chunk of calcium sitting there. So wiring she's an elderly lady. We've corrected the right side. And since then, she is pain-free. And she's really very happy with the relief that she has got. Now here, it's like we want to safeguard the patient and do a procedure properly as well. So what we have done till now is we managed to wire the LED. It was a struggle because, you know, there's just this thin line and this huge chunk of calcium sitting in the distal left main, and wiring that calcium just deflects your wire, and you have such a lot of problem with that. But eventually we were able to wire the vessel, and we struggled a bit, and then we took our microcatheter, and so just go through the slides with them.
Madam,
So
what was the wire?
After
What is the
wiring
wire?
the LED with a run-through wire, and then we take our microcatheter, and here also maneuvering the microcatheter was a struggle, but it went. It's a fine. So you can see, now you can see the left main, in the distal left main, you can see that there's almost 99% narrowing in the distal left main. So you can see that, right? So we wired this distal left main as well as the LED, and then we think this is such a tight lesion. We exchange this wire for a rota wire, and then we decide that we want to do a first plug with modification with a 1.25 burr. Now, we were also a bit apprehensive that whether we would end up with a stuck burr, but we felt that the lesion was so tight, we would gently do the plug modification. So we first took a 1.25 burr, it responded well. After this, we exchanged the 1.25 burr for a 1.75 burr. So we did rota with a 1.75 burr, and she tolerated that well. After this, we exchanged our rota wire for a normal wire, so this is the 1.75 burr going now. So as I said, we first did 1.25, then 1.75 burr. And it's like a really rock solid calcium there, and we really needed this 1.75 burr. So we managed to clear it. We had 3 runs with this 1.75 burr, each like 7 to 10 seconds each. Very gentle pecking motion, going forward, coming back. And after that, after rotablation, 3 runs of 1.75 burr, this is how the vessel looks now. So you can see it's even the proximal left vein where there was that solid calcium, that looks a lot easier. So now we take our run-through, please, can you show that? So we exchange it for a run-through wire, and the wire goes easily, and we exchange the rota wire for our run-through wire with the help of a microcatheter. We now take our IVUS catheter to have a look, and the IVUS shows that the calcium is very bad. So can we have a look at the IVUS run today that we took? So please, this is calcium. So this is calcium in the mid-LED, but we've cracked it with the 1.75 bar, you can see, right? So all this amount of calcium, can we go a bit more proximally? Yeah, it's running by itself. So there's this calcium. Can we go? This is the left main relatively free of disease. And if you go a bit back, you can see that the LCX ostia is just covered with a chunk of calcium. Now here, this is where we are up till now. We then took a scoring balloon, a 3.5 by, it was a 3.5 by 12 millimeter scoring balloon, right? A 3.5 by 10 millimeter scoring balloon, and we have, can you show them the scoring balloon? So this is the circumflex ostia, you know, it's covered with a chunk of calcium, which makes the wiring this vessel very difficult. So we were debating, she's an elderly patient, we've already treated her right coronary, we've opened up a very large RCA, she's tolerated it well, she's now pain-free. So we were planning that we would want to make this procedure as simple as possible, and instead of wasting time in trying to wire the LCX, we would go about treating from left main to LED as well as the mid LED. So this is where you found us. So we've done the scoring balloon, and now we were contemplating what to do. Should we attempt to wire the L6, which doesn't look very large, which has a lot of calcium in it, and I would hesitate to rota that vessel. It's a narrow caliber vessel. So here, this is us doing the scoring balloon 3.5 by 10, and we went to 12 atmospheric pressure. We then go down, so we did the scoring balloon dilatation just like a proximal optimization. So you can see that we've just opened up that chunk of calcium in the distal left main. Now we are planning to tackle the LAD, and for that we will take an NC balloon first. So this is where you found us. So we've done the right coronary artery. For the left, we have tackled the very tight lesion in the left main with first 1.25, then 1.75 burr. And then we saw that it was very dense. So we took a scoring balloon to further prepare our lesion. And now we are taking an NC balloon for the another scoring, but of a smaller size. This is 2.75 by 10 for the LAD. And can someone show the hemodynamics? So touch wood, she has tolerated the procedure so far, and as you can see, we have not used much dye or anything. We are just using minimum amount of dye, and that was one of the reasons that we didn't opt for OCT. So far, the procedure is this. We've done rota, we've done scoring balloon for the left main, and now we are taking another scoring balloon for the LAD.
Madam, what is the ejection fraction of this patient? Yes,
we showed it in the first slide. It is 46%. 46% ejection fraction.
Yes, tolerated very nicely, the patient.
Yes, because and also the first day last week when we were doing, we had no support from the left side. This day when we are tackling, so there is a support from the right side, and you can see the scoring balloon is not going down. It's stuck here. There's such a lot of calcium even. So we'll dilate here in the proximal LAD. So we've gone up to 14 atmospheric pressure with a 2.75 by 10 scoring balloons. And you can see we are facing resistance. Even though we've done rota, there's still such a lot of calcium left. I think what we need to do is we need to take a smaller sized NC balloon to tackle that and then take this scoring balloon. Maybe this scoring balloon was a bit too ambitious for us to take. So we'll take a NC balloon now, prepare a lesion further with the NC balloon, and then take this scoring balloon if required.
Madam, thank you. How much time we should keep inflated the scoring balloon?
Actually, you see, this is also something very variable. I mean, as long as your patient tolerates the ischemic burden, right? This patient is elderly. So the thing is, you want to have an impact with your scoring balloon. So you want to at least inflate it for 30, 40 seconds ideally, right? But if your patient cannot tolerate it, then you do it for a lesser time. Sometimes, we just inflate it and then deflate it, and that really doesn't impact our vessel at all. So you should give time for the vessel to feel the pressure, right, and to respond.
Thank you.
So now we've taken a 2.5. So we've taken a 2.5 by 7 NCU4, and obviously a scoring balloon is a lot bulkier than so that's why we were now this balloon is behaving quite well. So one thing about calcified lesions, you really need to prepare your lesion well before you attempt to put in any stent. Otherwise, you can be in a difficult situation. And one thing I forgot today is that I didn't introduce our team because we were so engrossed in this case. So please just, before I forget, let me introduce the team. So I'm Fazila Malik. This is Abdul Khayyum. He's always with me in most life cases. And he's our consultant here. Then we've got Mohsin. Mohsin is very famous. Everyone knows him. And there's Lipi, our Chief of Cath Lab Nurses. We've got Zahid, and we've got Maksura, and then we've got Niaz, another technician, and we've got Russell, who's helping us out with the groin. You know, that's also very important since we're doing these complex cases in an elderly patient, and we prefer the femoral lead for such complex cases. Someone to hold on to the groin and just oversee that there's no hematoma or anything, and we've got a trusted anesthesiologist, Dr. Khairul, who's been very supportive, taking care of the blood pressure, taking care of the patient, that she does well. So that's us working today. And it's quite a teamwork when you're facing such a complex case. So touch wood, we're now taking our scoring balloon.
Madam, can I ask you, what is the catheter size, 6 or 7?
7, absolutely 7, because you want to be comfortable, right? You're dealing with a complex case and you never know whether you would require 2 stents or what, so it's a 7.
7, yes.
And for a 1.75 bar also you would require a 7, so it's a 7.
Madam, did you go directly from 1.25 bar to 1.75 bar in rota?
Yes, I did. We did. So we went up to 14 atmospheric pressure and inflated. So now the balloon went down. It wasn't going down before that. So now we are taking our scoring balloon and preparing the lesion to our best of our ability. We'll check and see how and we need to give some GTN as well, please. So we are good here. In mid-LAD, elderly females, you always need to be careful. So that's us. So we've done NC balloon. Now we're doing scoring balloon. We've done rota with 1.75, but still there was a bit of resistance here. Maybe we can give some more of, yes. The ostia looked. Okay, right. Now what we'll do is we'll give some GTN and have a look and see how the vessel has opened up and what has happened to the circumflex. I personally think that here we want to give her relief from symptoms and possibly also help her because she's got such critical left main disease, so it will also improve her prognosis. She's 82, no surgeon would want to touch her in her right main, and she's very low body weight. So PCI was her only option, and very high risk PCI obviously. But touch wood, inshallah, we hope to do a proper job of this. And now let's take a cine. So now, so the LCX is holding on there, and I'm happy to not touch it. It's highly calcified. I don't want to increase the procedure time. I've really done a good job with the right coronary artery, and we think that if we can salvage the left main and the LAD, hopefully, God willing, she will do fine.
Madam,
any comments from the panel? I would be happy
Madam
to.
Amal, Professor.
Yes, please.
In this situation, like this situation, I think, is there any need to safety wire as a minimum to the LCX? Protective wire? Because LCX distal territory is good. Osteoproximal part is very ugly looking, but if needed in positional steering pathway, if needed to wiring or ballooning, so keep another wire.
The fact of the matter is, at the end of the day, we want a safe procedure with a happy patient. And I think, and here also we have to consider everything, the duration of the procedure, the complexity of the procedure, and the timing. So we have, as I said, we've already tackled the right coronary artery, and it looks good. And for the left, the main crux of the matter was that distal left main calcium, there, which was sitting like there. So we have managed to clear up most of it. The LCX is a relatively compared to the right as well as definitely to the LED, it's not that great a size. And the amount of energy we would need to, if you can look at the calcium there, and we saw by Ivers also, there's this chunk of calcium sitting like a wedge in front of the ostia of the LCX. Now, if we try to open this up, this might take hours. We might need to use lots of wires, especially wires that might potentially lead to further complications. So it's any procedure that we do is a check and balance. What are my benefits and what are the potential risks? For this 82-year-old lady with a compromised ejection fraction, very low body weight, I feel that so far we have done a safe and a good job. I mean, sometimes they say that this best is the enemy of something like that, you know, like you want to excel and then you end up maybe with a complication. So our aim here is to maintain everything safely and to end the procedure. So, the thing is, wiring the LCX at this point of time we don't want to do. We want to stent from left main to LED.
Madam, can I compliment you that if you wire the LCX, there is chance of wrapping of the wire. So
what did you say?
There may be wrapping of the two wires. So there may be some difficulty in the advancement of the devices you are using. So single wire in the initial point is a good choice. Because
yes, and you see, another thing you have to remember, this LED is a very large size vessel. Now, even if I wire the LCX and I think about doing rotor, which I don't, I would need to remove the wire from the LED.
Yes, you cannot keep the wire when you are doing rotor.
For our patient, as you have pointed out. So now we are taking a 3.5, 48 synergy. We're taking a synergy, and as you know, synergy, you can, even if there's mismatch in the size between the proximal and the distal, you can really do a proper job of that.
So, madam, do you not like to have a
one challenge is this is a large stent, right? So taking it into this very long stent into the vessel might be a challenge, calcified vessel. Here, if we had taken two smaller size stents, it would have been a lot easier. But you also have to think in Bangladesh about the economics, because we've already done a procedure in the RCA. We've used two stents there, and we don't want to increase the, just look at synergy. It went like butter. I'm so amazed. Honestly, I was like, who gave me this 48? I would have wanted two stents if I had, but they'd already opened it. And see, I'm so amazed with the synergy. Fantastic job, guys. So the 48 stent went like butter. Now this is also a credit to the synergy stent, definitely, but it is also, I think, a testament to the rotablation, you know.
Very
the
lucky,
rotablation really did the job, and of preparing the lesion. Before this, even taking microcatheter was a struggle, right? And now, so we have to go a bit down. Now if we check, please. The left main wasn't that bad, right? So the ostia was all right. So maybe we don't need to go to the ostia, so we'll push a bit more. Just have a look. Just final check, please.
It's okay.
Check.
No, it's okay.
Check, please. So, are you happy with the position?
It seems to be fine.
Yes, madam. Yes.
So, this is a 3.5, so we have to go very gently. And it's a calcified vessel, already rota, scoring, etc. have been used. So we give time, in the previous case, I think Professor Supriya Raman was talking that this is a metallic thing. You want it to, grow, get used to the vessel. You just don't want to rush it. Take things easy in life as well as in intervention, definitely. With rota, be gentle. In intervention, you can't afford to push or prod. You have to be very gentle. And if you think things are difficult, don't push. find an alternate thing to do for that. So I just pulled it a bit back. That's not my usual practice, but the left main is so roomy that we can afford to enlarge it there. So we've gone up to 12 atmospheric pressure, right? Now, when you're dealing with heavily calcified vessels, hopefully everything is fine. You look at the pressure, you look at the patient, you look at the ECG. Then you should give a puff of dye. Do that, because with calcified vessels, so it looks good. But when you're dealing with heavily calcified vessels, always with your balloon there, take a puff of and see whether there's any complication or not. So now we are taking a balloon for 4/6 for proximal optimization.
Madam, we are 5 minutes lag behind. I will be happy. We will be happy if you wrap up within 5 minutes. Then
yes. So after 4/6,
madam,
we'll
listen.
take a shot,
If it is not completed, then you should continue.
Of the rest of the vessel off screen also. That's fine. So we're finished almost.
Madam, do you not go
No, madam. You should continue. Then, if after talking, if you need further intervention, we will come back to within 12 minutes after the talk to see the result and for your final comments. So nothing to be hurry. If you wrap up within 5 minutes, it's okay. If it is not possible, then you should continue the procedure. Then we will come back to again with you with the final comments.
So,
Madam, you
did the proximal optimization. Yes, please.
Madam, you dealing the left main with LED standing, but you
Yes,
just
yes.
avoid any imaging. What is your
Excuse me, I
vision?
think you might have come late because we did imaging. We did IVUS and we showed the IVUS, and there was this huge amount of calcium in the distal part. If you want to, we are going to do an IVUS again. We have not avoided imaging. For the right coronary artery, we did imaging, and for this left also. Can you again show today's imaging, please? So this is the left main in the proximal part. It looks fine, but can we go down, scroll down a bit, please, where the amount of calcium is huge? Please go down. Mohsin. Yes, so we did IVUS, and we saw a huge amount of calcium there. Even after this, so this is the calcium at the tightest post after 1.75 rota. Before this, even the microcatheter was not going.
Madam, I believe that you should do one IVUS at the last.
Yes, of course we'll do an IVUS at the last, but before that we want to
whether it is
post-dilate the stent.
whether it is optimized
It's a very
or not.
large stent. After post-dilating, we'll do a last IVUS imaging.
Otherwise, you will remain unhappy.